Very good evening, students. Very good evening. So, good evening, Suraj. Good evening, Arya, Kalyan, Prakash. I hope you are having a very good day. And today we are going to discuss two important topics for your prof exams. Neonatology is the core of pediatrics, and in neonatology, the core is NRP. And you need to know NRP so that your baby does not land up into birth asphyxia. So these two important topics go hand in hand, and today we are going to discuss these two only, NRP and birth asphyxia. Good afternoon, Ayush. Good afternoon, Rajshri. Okay, so let's start without further ado. So we are going to discuss NRP and birth asphyxia. What is NRP? Neonatal Resuscitation Protocol. Neonatal Resuscitation Protocol. NRP is Neonatal Resuscitation Protocol. So you have seen resuscitation in, let's say, movies. So what do they do in resuscitation? So you must have seen in movies what happens. If someone collapses, an adult collapses, and they start doing chest compressions, they start giving mouth to mouth for breathe. But newborns are different. When we are resuscitating newborns, we don't start with chest compressions. We start with breaths first. We go on to chest compressions if effective ventilation is failing. If we are failing to give good breaths, then we go on to giving chest compressions. So babies are different that way. So remember that babies, they are born with good heart. They have a good heart and bad lungs. Good heart and bad lungs. So what we are doing, we are first supporting their lungs. We first do ventilation and then focus on heart. So remember the cornerstone of NRP. If anyone asks what is the cornerstone of NRP, the cornerstone of NRP is effective ventilation. So cornerstone of NRP is effective ventilation of NRP is effective ventilation. So baby is getting born. Your OBGYN friend calls you that delivery is going to happen. Baby soon going to come into this world. So please come and receive this baby. How many people trained in NRP are required to receive this baby? You need one, you need two, you need five. How many? So remember, minimum we need one NRP trained personnel. Minimum one is required. And if it is a high risk delivery, in cases of a high risk delivery, the minimum person that are required are two. Minimum is two. Maximum can be any number. You can take all of your friends there also and make a team. One person will be the team leader, one person will receive the baby, one person will do this step, one person will count the heart rate, one person will have the timer on. You can have as many as possible, but minimum one. And if it is a high risk delivery, you already know that this is a high risk delivery, then two minimum are required. Okay, so your OBGYN friend is calling you, so and you go to the delivery room. In the delivery room, what will be the temperature of the delivery room? The temperature of the delivery room is going to be 25 to 28 degrees Celsius. And the delivery station would be there in the corner. It should not be near to the door. We want this delivery corner to be free from any draft of air. So it should have been in a corner where there is no free draft of air. You go there, and now you're going to ask 4 questions before the birth of the baby. Remember, before the birth of the baby, you need 4 questions. Before birth, 4 questions. 1, 2, 3, 4. What is the first question? you're going to ask your OBGYN friend is this is a term baby or a preterm baby. So you need to know the gestation age of the baby, because if it is a term baby, the risk of complication is going to be less and you can easily manage it on your own. One person is enough. But if it is a preterm baby, you would need help of your friends. You will need someone else to join in. So the first question is going to be, what is the gestational age of the baby? Then you are going to ask if there is any maternal risk factor. If there is any maternal risk factor, what do I mean by that? Was this a complicated pregnancy? Was there is some abnormality in the scan that you should know? So all the maternal risk factors, additional risk factors you should know. The third question that you are going to ask is meconium stained liquor. Meconium stained liquor. What is meconium stained liquor? If the liquor is not clear, it is meconium stained, then this is going to be a high risk delivery, and again you are going to need one extra personnel. Fourth is umbilical cord management. Umbilical cord management. What do I mean by that? As soon as the baby is born, we do not immediately cut the cord. We have to do delayed cord clamping. Delayed cord clamping. Why do we do this delayed cord clamping? Why we are not immediately cutting the cord? Because this delayed cord clamping ensures that some amount of additional blood goes to the baby. Why we need this small amount of extra blood go to the baby? Because it decreases the chances of anemia in future life, in later life, not in the neonatal period, but in the later life. This little extra blood is going to decrease the chances of anemia. This delayed cord clamping, we delay cord clamping for 60 seconds or 1 minute so that there are lesser chances of anemia in later life, right? So this is the 4 questions that you are going to ask before birth. Yes, Arikumar, you are already coming to after the birth. But remember, before the birth, you have to ask all these questions and decide whether you are eligible alone to handle this case or you want more people to join in, depending upon the risk. So these are the 4 questions. Okay, so now the baby is born. After birth, you are going to ask the 3 questions. TTC. What is TTC? Term, tone, cry. Term, tone, cry. Whether this baby is a term baby, how's the tone of the baby? Is the tone good? Did the baby cry? These 3 questions. So before birth, 4 questions. After birth, 3 questions. If answer to all of these questions is yes, that is, it is a term baby, tone is good, and the baby cried immediately after birth, nothing has to be done. You just have to give routine care. And you all know what is the routine care? We do all the 5 cleans: clean hands, clean surface, clean cord, clean cut, all the things, 5 cleans: skin to skin contact with the mother, establish breastfeed, give vitamin K prophylaxis. All of these routine care you have to do. But if answer to any of these questions is no, then along with the routine care, you have to do initial steps of resuscitation. What are these initial steps of resuscitation? Remember it by the mnemonic PATS. PA is position airway. That is, we keep the baby in a sniffing position, a slightly extended position so that the airway gets open. Dry pat the baby. And S stands for stimulation and suction. How do you stimulate the baby? You gently rub the back of the baby, you flicker the soles of the baby. Remember, this has to be gentle. You very gently rub the back, gently flicker the soles of the baby. Don't do it vigorously like we see in the Bollywood movies. They slap the baby on the buttocks. We don't stimulate like that. Just gently rub the back of the baby, flicker the soles of the baby, and suction. Suctioning is done if there are some secretions. And how do we suction? We suction mouth before the nose. M before N. Why we are doing this? Because newborns are obligate nasal breathers. If I clear out the nose first, what will happen? The child will breathe, and if there is any secretions in the mouth, the baby can aspirate that. So we firstly clear the mouth and then clear the nose. So mouth before the nose, right? And what is the sniffing position? This is the sniffing position. We slightly extend the neck, extend the head of the baby so that the airway opens up, airway comes into the line. So this is the initial steps of resuscitation. If the answer to the three questions, term, tone and cry, is no, any of these is no, then along with the routine care, you do initial steps of resuscitation. And the mnemonic to remember that is pads. Okay, so after the initial steps of resuscitation, most of the babies, they revive. The tone will improve, they start crying. But if the baby is not responding to this initial steps of resuscitation, you have to start positive pressure ventilation. So what happens if my baby is not responding to this initial steps of resuscitation? I will check the heart rate of the baby. If the heart rate is more than 100, but the baby has labored breathing, then I will take this baby to NICU. And give supportive care. This baby could require oxygen, could require CPAP therapy. But if the heart rate of this baby is less than 100, then you have to start now positive pressure ventilation. Remember, we first focus on ventilation. If despite effective ventilation the baby is not responding, then you go to heart, then you start chest compressions. So we will start with positive pressure ventilation. This positive pressure ventilation should be started within 1 minute of birth. So all of these steps, stimulation, suction, checking the heart rate, that should be done within 1 minute. This is known as golden 1 minute. So you start with positive pressure ventilation. How can you give this positive pressure ventilation? I can give it through ambu bag, or I can intubate the baby and then give it. Right? Ambu bag, face mask, easy. Intubation will require a skill. You would need a pediatrician like me to do that. So the easier one is ambu bag with face and mask. Right? So positive pressure ventilation, you give that for 30 seconds. Remember, this positive pressure ventilation should be effective positive pressure ventilation. That means the chest drive should be there. There should be heart rate increase. That is effective positive pressure ventilation. If your seal of the face mask is not appropriate, that won't be effective ventilation. So we give effective positive pressure ventilation. After 30 seconds of effective positive pressure ventilation, if the baby is not responding, that means the heart rate is now less than 60, then you have to start now chest compressions along with ventilation. How many chest compression and ventilation? The ratio has to be 3:1. That means 3 chest compressions and 1 ventilation. So what do we do? You do 1, 2, 3 breath. 1, 2, 3 breath. 1, 2, 3 breath. So this is 3:1. There are two methods by which you can do this chest compressions. This is the first method, that is the 2-thumb method, or you can do the 2-finger method. Which one is more effective? This 2-thumb method is more effective because in this 2-thumb method, base is made by your palms. So you have ensured that the base on which the baby is lying is in your control. So there will be effective compressions. But if you're doing it with the fingers, I don't know what is the status of the mattress beneath. If it is too soft, then this compressions could be ineffective. So remember, 2 methods, 2-thumb and 2-finger technique. 2-thumb is better. And 3:1 is the ratio. And how many events would be there? There will be total 120 events. How these 120 events are calculated? So there will be 90 chest compressions and 30 breaths in 1 minute. So for 1 minute, you have to give this chest compressions and ventilation. If after this 1 minute, still the baby is not responding, still the heart rate is less than 60, now what you have to do? My chest compressions are also not working. Chest compressions are not able to revive the heart rate. Now you have to give a drug. Which drug? IV epinephrine. right? After giving this IV epinephrine, I can repeat 2 to 3 doses. If despite giving IV epinephrine, the baby is not responding, then what could be the cause? I have taken care of the lungs, I have given effective ventilation, I have taken care of the heart, I have given compressions, I have given epinephrine, but still the baby is not responding. So what could be the reason? If epinephrine also fails, then think of two things. First is pneumothorax. First is pneumothorax. Quickly check the breath sounds. If on one side the breath sounds are decreased, that means pneumothorax has developed. Then obviously what I'm going to do, I'm going to pierce through a needle, do a needle thoracotomy and revive that and relieve that pneumothorax. So needle thoracotomy. Second could be some bleed, some underlying bleed. So if the breath sounds are also fine, then and you are suspecting some bleed, if you are suspecting bleed, then we give volume expanders, we give NS volume expanders. So this is the core structure of the NRP. Firstly, you focus on positive pressure ventilation. If despite 30 seconds of effective positive pressure ventilation, the child is not improving, you start with chest compressions. If despite 1 minute of chest compressions, the child is not improving, then you give IV epinephrine. If despite IV epinephrine the child is not improving, then you suspect two things, pneumothorax and bleed. For if there is pneumothorax, you do needle thoracotomy, and if it is there is a suspicion of bleed, then you give volume expanders. So this is all about the core of the NRP. Now, if you have ever gone to a delivery room, then you must have seen this flow chart. Right? Some things they are given in this diamond shape, some in the box shape. So these diamond shape are the questions or the assessment that we do, and these boxes are the actions that we do. So you can see the questions are giving term, tone, cry in diamond, and these boxes have what we have to do. You have to warm, you have to position airway, dry, stimulate, all of that. So this is to be covered. So now coming to some important questions that the examiners can ask you. So timeline is the major thing. So golden 1 minute, you should know what is golden 1 minute. Golden 1 minute, that is from the birth, if positive pressure ventilation is required, that should be given in 1 minute, positive pressure ventilation. After how many seconds of positive pressure ventilation, you have to start chest compressions? 30 seconds. After 30 seconds of positive pressure ventilation, you have to start chest compression if the heart rate is less than 60. After 60 seconds of chest compression, if the heart rate is again less than 60, you start with epinephrine, right? So this is all about NRP. So we have got to the main concept of NRP. Now, if someone asks that you have done all the efforts, there should be one point at which you have to stop. So when do we withhold the efforts, resuscitation efforts? If despite 20 minutes, of your effort, resuscitation effort, the baby is not reviving, then you withhold these resuscitation effort, withhold the resuscitation efforts. Then you have to let go of that baby. The baby is not going to revive any soon. Okay, so this is all about the basics of NRP. As far as your prof exams are considered, they are going to give either a short note or a long question. If long question is there, please make that entire flowchart, and in short also give that short. In long question, you have to give additional things about, like write about the chest compressions, how do you do chest compressions, the rate of the chest compressions, the events, what is the technique behind that, and the dosage of adrenaline. So let's talk about the dosage of adrenaline. So injection adrenaline, उधर से जाओ, उधर से जाओ. Injection adrenaline. So whatever is the dose of injection adrenaline, if you have ever seen an ampule of adrenaline, it is 1:1000 dilution. So whenever you are using IV, the dilution has to be 1:10,000. 1:10,000 dilution. 1:10,000 dilution, what is the dose that we give? We give 0.2 ml per kg of dose. This we give through umbilical venous catheter, umbilical venous line. Okay, Atul Singh is asking for timeline once again. So timeline, students, firstly birth till PPV, golden 1 minute, that is 60 seconds. Golden 1 minute. Then from PPV till chest compressions, 30 seconds. Effective positive pressure ventilation till chest compression, 30 seconds. And from chest compressions till epinephrine, again 60 seconds. 60 seconds. 1 minute of chest compressions. So this is the timeline. And when you have to stop the efforts, after 20 minutes you have to stop the efforts. Okay. So this is about the timeline. Understood? Atul, if is everything fine? Did you understand the timeline now? Okay. So we were on the dose. I told you the dose, 1:10,000 dilution, 0.2 ml per kg of the dose has to be given. Okay. What else the examiner can ask? The examiner can ask about bag and mask ventilation and intubation. So remember, these are the overlap topics with anesthesia, bag and mask ventilation. So bag and mask, you know, there will be a mask, there will be an ambu bag attached to it, and you give breaths through that. But you have to ensure that this mask has appropriate seal. Appropriate seal. It should cover both. It should cover both mouth and nose. It should cover both mouth and nose. This is a non-invasive technique. You can also do that. You just have to ensure the size. But if while giving this breath through ambu bag, you see there is no chest rise, that means this is not effective ventilation. Appropriate chest rise and increase in the heart rate should be there. Okay. And they ask, what is a contraindication of doing this bag and mask ventilation? What is the contraindication? There is one contraindication of bag and mask. Can you tell me what is that contraindication? In which scenario you are not going to give this bag and mask ventilation? It is congenital diaphragmatic hernia. Congenital diaphragmatic hernia. Yes, congenital diaphragmatic hernia. What is happening in congenital diaphragmatic hernia? The contents of the abdomen have reached to my thorax. So when you are giving this bag and mask, I know I'm covering both mouth as well as nose. So some amount of air is also going to my gut. So those gut will expand and prevent the expansion of my lungs. So that's why in congenital diaphragmatic hernia, you have to intubate the child and then give breaths. So with that comes the intubation, endotracheal intubation. So when we talk about newborns or pediatric population in general, you know, there are two types of blade. If you have ever seen a laryngoscope and the blade, one is a curved blade, one is a straighter blade. Which one you use in neonatal and pediatric population? We use this straight blade, right? We don't use this curved blade, we do use the straight blade. Can you tell me what is the name of the straight blade? It's Miller's. And this is Macintosh. So we use the Miller's one. They ask the size of the laryngoscope blade. So laryngoscope blade sizes, if it is a preterm baby, then you use the smallest one, that is the 0 size. And for term baby, we use the 1. Right? So this is all about endotracheal intubation. Any doubt regarding NRP till now? Any doubt? Okay, I think everything is clear till now. Okay, so now let's move back to the flow. Let's move back to the flow. So can you see this flow? Can you see this flow? We have discussed each and everything. Look at this table. Look at this table. The target SpO2. Target SpO2. In my NEET PG exam, they asked this. So what is this target SpO2? After birth, we have to match these targets. We usually start with, if it is a term baby, then you connect oxygen over here or not? No. If it is a term baby, I will start the resuscitation with 20% oxygen only. That is the room air. And for a preterm baby, 21 to 30%. The goal is to match the target. If our target is achieved, you continue the same. If target is not achieved, then you have to increase the oxygen values. So how do you remember these target of oxygen saturation? Very easy. 1 minute, 2 minute, 3 minute, 4 minute, 5 minute, 10 minute. You start with 60, go 5. So at 1 minute, my target is 60 to 65. After that, 65 to 70, then 70 to 75, 75 to 80, 80 to 85. And in the last 10 minutes, it's 85 to 95. 85 to 95%. Right? So this is the target SpO2 that has to be reached. Target SpO2 that has to be reached. Okay. Okay, so baby is born and the scoring starts from birth itself. At birth only we are given a score, we are giving some marks. What is that score? You all know what that score is? Yes, that score is nothing but APGAR score. Nothing but APGAR score. So what is APGAR score? APGAR, APGAR. So APGAR is actually the name of the scientist or the person who discovered it. But we can use this term APGAR to remember the mnemonic. What is APGAR? APGAR. APGAR. A is for appearance. P is for pulse rate or heart rate. G is grimace response. A is the activity of the baby. And R, what is R? R is the respiration, respiratory efforts. Respiratory efforts. And each of these components is graded 0, 1, 2. 0, 1, 2. As we go from 0, 1, 2, as we increase the marks, the baby is getting good. Lower the score, the baby is bad. Higher the score, the baby is good. Simple logic. What would be the maximum marks? 5 components are there and the maximum is 2. So the maximum is going to be 10 and minimum is going to be 0. So firstly, let's talk about appearance. If the baby is appearing blue to you, you give 0. If the body of the baby is pink, extremities are blue, then you give 1. And if the baby is entirely pink, you give 2. Then comes the pulse rate or the heart rate. If there is no heart rate, 0. If the heart rate is there but it is less than 100, 1. If it is more than 100, 2. Then comes the grimace response. If you do suctioning, the baby should have a grimace or baby should cry, resist that. So if there is no such grimace response, 0. If the baby has grimace response, 1. And if the baby cries in response to that stimulation, 2. Then comes activity. If the baby is lying limp, no tone, then 0. If there is partial flexion, some amount of flexion is there, 1. If there is complete flexion, 2. Complete flexion, 2. And lastly, respiratory effort. If the efforts are absent, then 0. If efforts are there, but the breathing is labored, then 1. And if there is good efforts, the baby is crying good, then 2. Right, so this is all about APGAR score. So this completes the major chunk of NRP. In NRP, there are some older concepts and some newer concepts that I want to tell you. some older concepts and some newer concepts. So firstly, let's talk about the older concept. Now it is not used, but the examiners are still fond of asking about these terms. These terms are related to MSL baby. Remember MSL, meconium stained liquor, one of the questions that we asked before birth. So if MSL is there, then earlier we used to differentiate these MSL babies into either vigorous babies or non-vigorous babies. What are vigorous babies? Vigorous babies are those babies whose heart rate is more than 100 and the activity is good. Then we have non-vigorous babies. What are these non-vigorous babies? Whose heart rate is less than 100 or the activity is poor. Earlier, in this non-vigorous baby, tracheal suctioning was done. But now, no such thing is recommended. Now we evaluate or manage both these babies as we are going to manage any other baby. Meconium stained liquor does not make any difference. So remember, in non-rigorous baby, now you follow the normal NRP only. No routine tracheal suctioning is done. No routine tracheal suctioning is to be done. No routine tracheal suctioning is. Okay, so this is the older concepts. Now let's move to a new concept. If you follow me on Instagram, the handle is Baby Doctor Journey. If you follow me there, then I put up this update. This update is actually very new. Just in October end this came. So it is a very new thing, and examiner can ask you in your exam as well as in your viva that tell the recent updates of NRP. So what are the recent update? So let's write up these updates. So older we have discussed, now the updates. These are very recent 2025 updates, right? This happened in October 2025. Last October 2025. So what are these updates? So major points let's cover. So firstly, they have included birth and cord management plan as actions within the first minute. Remember, in the first minute we discussed about pads, position airway, dry, suction. Now they have included one extra point. That one extra point is nothing but they have added birth and cord management. बस लिख दिया है वहाँ पे. They have just added the statement cord management in first minute. This is the first update that you need to know. Second, PPV. Remember PPV? We had discussed positive pressure ventilation everywhere. Now, instead of PPV, instead of positive pressure ventilation, this term, just this term, is replaced by ventilation. Now in the text, they are not using PPV. They have just replaced with ventilation, right? Just for the sake of update, they have added this. The core stays the same. We are still using those ambu bags. Just we are not now naming it as PPV. We are now naming it as ventilation. So the term PPV is replaced by ventilation. Then comes delayed cord clamping. Earlier, this delayed cord clamping was 30 to 60 seconds. Now they have removed this range. They have given a single value, that is 60 seconds. 60 seconds. Okay. Then comes the target saturation table. Remember the target saturation table? This target saturation table, if you remember, it started from 1 minute. Now it starts from 2 minutes. So values are same. So it starts from 70 to 75 now, right? 65 to 70 now. So this table starts from 2 minute now. Right? Then the fifth update. What is the fifth update? The fifth update is that initially the preterm and term babies, I told you, preterm we start with 30% oxygen saturation and term baby we start with 21%. So they have further broken down the preterm babies. How they have broken down? They have broken down that the oxygen concentration, the FiO2 oxygen concentration in less than 35 weeks, you give 21 to 30%. But if the baby is more than 35 weeks, then you give 21% only. You give 21% only. Right? 21%. This was something which was the earlier concept. This was the earlier concept. They told that preterm babies less than 35 weeks, 21 to 30%. And after 35 weeks, 21%. Now what is new? What is the update? The update has further broken down these preterm babies, So they have divided into less than 32 weeks, 32 to 34 weeks, and then 35 weeks and above. So 35 weeks and above stay the same. 35 weeks and above, 21%. 32 to 34 is 21 to 30%. And less than 32 is 30%. Right? So they have divided in such a way. So this is the update. Then comes the ventilation rate. Remember PPV ventilation rate. What is the ventilation rate? The normal respiratory rate of a newborn is 40 to 60. So we used to give, earlier they used to give this rate as, ventilation rate as 40 to 60 breaths. 40 to 60 breaths per minute. Now the update is, what is the update? The update is 30 to 60 breaths per minute. So this is the next update. Then the update is about ET tube size. Right? We discussed about the laryngoscope blade, 0 size for preterm and 1 for term. I purposely omitted this tube size because I have to clear the earlier concept and the update. So what was in the 8th edition earlier concept? Depending upon the weight of the child, we used to give this tube size. We have to decide the tube size. So if the weight of the baby is less than 1 kg, 1 to 2 kg, then 2 to or above 2 kg. If less than 1 kg, then we used to use 2.5 mm tube. After that 3 mm. After that 3.5 mm. Now again they have broken down these chotu bachas, these preterm bachas of the weight. Now the weight bands are different. What is the update? Let's see the update. So the update says less than 800 grams. 800 grams to 1200 grams, that is 1.2 kg. Then 1200 grams to 2000 grams, that is 2 kg. And above 200 grams. Right? Simple terms, less than 800 grams to 1.2 kg, 1.2 to 2 kg and above 2 kgs. So now they have said that in both of these categories, you have to give 2.5 mm. And they have given this star mark over less than 800. That if 2.5 mm is still big for the baby, go for even smaller 2 mm tube. This is optional. After that, it stays the same, 3 mm, 3.5 mm. So this is the update. Earlier it was easier. Now they have made this additional band and given this star that for less than 800 babies, 2 mm tube is optional. Then comes the next update. So you intubate the baby, put the tube. Now you have to fix that tube. How deep that tube has to go? How deep this tube has to go? Earlier, ET tube depth. Earlier, how we used to measure? Earlier, it was the nasotracheal length. Nasotracheal length was given. Now, nasotracheal length was measured, and according to that, the tube was inserted. Now update says that you have to measure from the anterior edge of the baby's upper gum, that is maxilla, in the midline, right? So now it is gum to tip rather than lip to tip, right? Gum to tip rather than lip to tip to lip. Okay, so this is the update. So the very vague update that instead of nasotragal length, now you do anterior edge of the mouth till the tip. So now you do gum to tip, not tip to lip. So this is the update over here, right? So these 8 points, are the core points that you have to write in your exam. I'm pretty sure if the examiner is in a good mood, that means in a very exciting, adventurous mood, he's going to ask you, he or she is going to drop this question, tell the recent updates. And in the Viva also, if the Viva is going very good, then the examiner can ask this, that can you tell me the recent updates that have just come in 2025? So you should know, I have made these update points in front of you, right? So these are the update points that you need to know. So majority of NRP is done now. Let's move to the next topic. The next topic is birth asphyxia. So if you have heard me throughout, then why we are discussing this NRP so much in detail? Why we are discussing this NRP so much in detail? Because we don't want birth asphyxia to happen. The first cry of the baby is very important. Why this first cry of the baby is important? Because as the baby cries, the baby gets that oxygen, and this oxygen is very important for the vital organs of my body. When the baby was inside the womb, all the oxygen was given through the umbilical cord, but as soon as the baby is born, baby has to breathe now, lungs have to become functional. If the baby does not cry after birth, what will happen? Asphyxia will happen. What is asphyxia? You all know, whenever the oxygen is deficient, there is asphyxia. And if there is asphyxia, organ damage would be there, and most important organ we have is brain. So if birth asphyxia happens, the important organs like brain, kidney, gut, all of these will not get oxygen, and there can be damage and long-term sequelae that we don't want to happen. So next time you go into delivery room, you have to prevent this birth asphyxia by doing good NRP, good resuscitation. So let's begin this NRP this birth asphyxia section. Birth asphyxia section. So in your exam, they can ask you a short note on birth asphyxia. They can ask you HIE. So both of these questions we are going to discuss. So whenever they are asking you a short note, you start with definition. But here in birth asphyxia, there is not a single definition. There are definitions. Why am I telling you definitions? You will get to know very soon. So let's talk about the first definition, which was given by WHO, that is World Health Organization, WHO. So what did the WHO say? WHO, very simple definition. We all understand what is perinatal asphyxia. The baby did not cry after birth, and because of that, oxygen delivery is restricted. So WHO came up with a very simple definition that if the baby has failed to initiate breathing, or the baby took a breath but did not sustain that breath, that is perinatal asphyxia, the asphyxia that is happening around the birth. So WHO said the definition is very simple: failure to initiate breath, initiate breathing, or sustain breathing, sustain breathing. Very simple definition, right? For us medical students, the definition should not be this much simple. We should be tortured by heavy terms and heavy words, right? So that no other people, no non-medical should not understand our language. So then comes NNPD. NNPD. NNPD came up with a slightly tough definition to make our lives tougher. So NNPD is National Neonatal and Perinatal Database. National Neonatal and Perinatal Database. Perinatal Database. What this NNPD said? This NNPD said that the WHO gave a very simple definition. Let me give some fancier definition. Let me give some points that only medicos could understand. So NNPD in fact gave two definitions: moderate asphyxia and severe asphyxia. These definitions were on the basis of APGAR score at 1 minute. If the APGAR score was 4 to 6 at 1 minute and the baby had slow breathing or the baby had slow breathing or gasping, then it is moderate asphyxia. But if the APGAR score is less than 4 at 1 minute or the baby is not breathing, this is severe asphyxia. Right? So NNPD gave this definition and all our medical students, medical community crammed this definition overnight. Right? Again, not such a tough definition, you can easily remember. But our lives need to be tougher. So comes the third definition that was given by AAP. What is AAP? This is not Aam Aadmi Party. What is AAP in pediatrics? It is American Academy of Pediatrics. American Academy of Pediatrics. They said that we need a tougher definition. Very simple definition. We need a tougher definition. So they gave a tougher definition depending upon the pathophysiology of asphyxia. So what is happening in asphyxia? We all know there is deficiency of oxygen happening. There is hypoxia happening. So because of this hypoxia, what will happen? Your body will switch to anaerobic respiration. There is no oxygen. So my body will switch to anaerobic respiration. Because of this anaerobic respiration, what will happen? What is the byproduct of this anaerobic respiration? Lactic acid. So there will be lactic acidosis. Also, important organs are not getting oxygen. So my organs will be affected. Which important organ will be affected? My brain would be affected. This is known as HIE, Hypoxic Ischemic Encephalopathy. And other organs most common involved is kidney. Apart from that, my gut can also be affected. So depending upon this pathophysiology, AAP, American Academy of Pediatrics, gave a definition. So this definition had 4 points depending upon this pathophysiology. First, I told you there will be lactic acidosis. So if you take sample from the umbilical cord of this baby, there will be acidosis there. So the first point of this definition says that you are going to see profound acidemia, that is pH less than 7 in umbilical cord blood. In umbilical cord blood. Second, they gave APGAR score. That APGAR score should be less than 4, that is 0 to 3. But remember here, they told about 5 minutes APGAR, not 1 minute APGAR like NNPD. Third, I told you there will be organ affection. Firstly, brain affection. So there should be evidence of CNS dysfunction. And apart from brain, all other organs would also be affected. So there will be evidence of multi-organ involvement, multi-organ dysfunction. So these are the 3 definitions of birth asphyxia that you need to remember. I know it's a lot, but slowly you'll get a hangover of it. You need to know the pathophysiology and easily you can remember these definitions by repeating again and again, saying it loud in your mind and understanding. Right? So in your exam, if they're asking you birth asphyxia, mention these 3 definitions and the pathophysiology of birth asphyxia. Right? Birth asphyxia. So when we talk about birth asphyxia, another favorite question of examiner is HIE. Write a short note on HIE, Hypoxic Ischemic Encephalopathy. And in HIE, you will mention this perinatal asphyxia scenario and tell about the stages of HIE. So let's revise together the stages of HIE, hypoxic ischemic encephalopathy. We have 3 stages: stage 1, HIE stage 1, HIE stage 2, HIE stage 3. If you have heard NRP lecture very thoroughly, you will go to the delivery room and resuscitate the baby fine, and there will be no to minimal damage to the brain of the baby. But if you don't do NRP well, if you don't listen to me, don't listen to the lectures, then what will happen? The baby is not crying. Prolonged asphyxia can damage the brain. So as depending upon the degree of damage that has happened to the brain of the baby, these are the stages 1, 2 and 3. 1, no to minimal damage. 2, slightly more damage. 3, severe damage has happened. So you have to ensure that the baby is no damage or just mild damage. HI1 stage is favorable. As you go from 1 to 3, the prognosis would be poorer and poorer, right? So stage 1 is mild HI, stage 2 is moderate HI, this is severe HIE. So firstly, let's talk about the differences in all of these scenarios. Firstly, mild HI. So if we talk about general condition of the baby, then mild HI baby would be dull looking or alert looking. This baby has no to minimal damage. This baby is going to have an alert state. As you go from 2, 3, the baby will be initially very lethargic, then the baby will be full tone comatose. So firstly, the baby will be lethargic and then comatose. Right? Then you will check the neonatal reflexes. Stage 1 baby has no to minimal damage. So this baby is very alert. You will elicit the reflexes, and these reflexes would be very much pronounced. But as you go further, firstly there will be sluggish reflexes, then there will be absent reflexes. Then what about seizures? If there is brain damage, the baby will throw seizures. In stage 1, obviously there is no to minimal damage, there won't be any seizures. In stage 2, moderate HIE, seizures would be there. You will appreciate seizures. In stage 3, though the brain damage is there, but the baby is full tone, comatose. So the physical manifestation of seizures is rarely appreciated. You have to put EEG over the leads to pick up any seizure activity, if any, right? So seizures are not seen over here. EEG can pick up. EEG can pick. Right? So if you have to choose one, HI2 or HI3, in which seizures happen, HI2 seizures are seen. Right? After seizures, let's talk about the basic things that you need to remember. So remember what happened in hypoxia. There was a state of stress. So initially, the sympathetic system gets activated. So in HI1, there is activation of your sympathetic system. In HI2, parasympathetic gets affected. And in HI3, both parasympathetic and sympathetic dysfunction is there. There's completely autonomic dysfunction. So what will happen in all of these scenarios? Firstly, talk about pupil size. You have read in pharma also, opthal also. If sympathetic system is activated, there is mydriasis, dilation of pupil, or meiosis, there is mydriasis. So you will see mydriasis. Here you will see meiosis. What about HI3? Both parasympathetic and sympathetic are affected. So there will be mid-size non-reactive pupil. Same goes for the heart rate. Sympathetic system is overactive, so heart rate would be increased. Here heart rate would be decreased. Here the heart rate would be very irregular. Lastly, let's talk about the outcome of these babies. So HI1, I told you, no to minimal damage, so the prognosis is good. In HI stage 2, now some damage has happened. Seizures are also happened. So 80% of the cases are going to have good outcome, no neurological sequelae. But 20% have neurological sequelae. And once the child slips into stage 3, no child is going to be ever normal. 50% usually head die and 50% have poor neurological sequelae. Poor neurological sequelae. Right? So this is about the staging of HI. They ask about the investigations, what all investigations you have to do over here. So investigations, remember, the easiest investigation, screening investigation would be a cranial ultrasound. It can tell me the extent of damage, but the definitive is going to be MRI. MRI will give better definition, better anatomy lineation. Treatment is nothing. Treatment is supportive. Once the damage has happened, there is nothing such that we can do. We just give supportive therapies to these babies. Right? So this is all about your perinatal asphyxia section. So with that, we end up our today's session, neonatal resuscitation and perinatal asphyxia. If there is any doubt regarding any of these topic, or you want me to cover something a little more in detail, feel free to drop that in the comment section and we will discuss that, or else we can wrap up this session. Thank you, Captain Jack Sparrow. You can stop spamming the comment section now. Malignancies is not the topic of today. We are discussing neonatology today, NRP and birth asphyxia. If a related topic is of doubt, then we can discuss that. Okay, I believe there is no such query. So with that, we end the session. Drop comments if you want to something improve over that. And I hope this would be helpful in your exam. Okay, so you can explore Farre for all the other subjects too. We are doing that, these small sessions, and that would be very helpful for your exam. For each and every subject, we are doing that. Fourth Prof Farre is ongoing now. We also have a session tomorrow. You can download the MedEd tab and explore the Farre section. And thank you for being very cordial throughout the session and dropping genuine doubts. With that, have a very good evening, have good hearty dinner, and have a restful sleep. All the best for your exam. The name of my channel is Dr. Divya Madan only, and apart from that, we have a lot of videos over here on PW MedEd channel also. And if you want all the lectures, then my entire lectures, the pediatrics course, is available on the PW MedEd app. You can go through that also. Notes will be shared. Definitely notes will be shared. Try to make your own handwritten notes from these notes, so that in the exam also you have a practice of writing. You don't have to think and write. It should be muscle memory. Okay, so a very good evening everyone. Bye bye. Let me take a leave now. Thank you.